Good afternoon, everyone. Thank you for the privilege of the podium. My name is Danny Moe. I'm currently an MIS fellow at Emory University. I'm very glad to be joining the WashU St. Louis Bariatric group in a couple of months. And I'll be presenting how does sleeve gastrectomy impact eating-related symptoms, emotional distress, and behavior using the body cue proms. I have no relevant financial disclosures. So I don't have to tell this group that obesity is a national epidemic, and metabolic and bariatric surgery is one of the most effective therapies for obesity. You know, when you look at quality outcomes that we measure right now in a systematic way for bariatric surgery, we look at things like mortality, reoperations, leaks, bleeds, readmissions, when in fact, those things happen relatively rarely. What happens a lot more commonly, or almost all the time, is patients undergo a transformation in their eating-related experience. So this includes eating habits, the symptoms associated with eating, physical function, and quality of life. These happen all the time, and yet we do not measure this in a systematic way. These type of important clinical outcomes can be captured by something called PROMs, which are patient-reported outcome measures. These are just standardized surveys that captures the patient's voice. Now, there's the body cue eating modules is a specific PROM that's designed just for bariatric patients. And these modules assess 3 different scales that include eating-related symptoms, eating-related emotional distress, and eating-related behavior. And our hypothesis is that in a population after sleeve gastrectomy, these scales, these metrics improve. So this is a retrospective cross-sectional analysis of PROMs that was collected at the Emory Bariatric Center over a course of a year between 2023 and 2024. And the inclusion criteria is all adults that was evaluated at the Emory Bariatric Center. To date, this entire initiative has collected over 5,000 PROMs, and I will say we have a compliance rate of over 80%. And we achieved that high compliance rate through very thoughtful design. So before a patient's clinic visit, they get a survey, an email link. When I say the survey, it's the PROM itself. They get it 1 day, 3 day, and 5 day before the clinic. So they have 3 opportunities to complete the survey. If they somehow ignore all those 3 emails, they get handed a tablet. So you really have to try to avoid filling out this survey. In terms of results, overall compliance, 81%. We have 4 different types of clinic types, so it ranges in compliance between 67 and 95%. Another important thing I just do want to emphasize is that our clinicians actually regularly review these surveys. In my area of research is in PROMs. It's very, very rare that you see a PROMs program where clinicians regularly review the survey data. In fact, if you look under the hood of most PROMs programs, especially bariatric programs, it's more for research, and the clinicians, they see it as, okay, we collect the survey, we'll see the long-term aggregate data, but not on a day-to-day basis. And the strategies to improve compliance, we have weekly compliance reviews with all the stakeholders that include the IT staff, the clinicians, and very importantly, the front desk staff. So in terms of baseline demographics, we have the pre-op and post-op groups. And the post-op group is a few years older than the pre-op group. They're all similarly female. We got around 90% female. In the BMI, we have about a 15% total body weight loss over the course of pre-op versus post-op. And the average is about 3 years or so, if you average all the post-op. We then broke down the post-op groups into different time intervals, 0 to 6 months post-op, 7 to 12 months, 1 to 2 years, 2 to 3 years, and beyond 3 years. So here's our data. So on the x-axis here, you see all the symptoms, so nausea, vomiting, regurgitation, et cetera. And the y-axis is the percentage of patients who ever experience these symptoms. And if you look at the bottom here with the dark navy, that's the pre-op, and as it gets lighter and lighter, it's 0 to 6 months post-op, 6 to 12 months post-op, 1 to 2 years, et cetera. If you look at nausea and regurgitation, you see that at around 1 year post-op, people more frequently experience nausea related to eating. Now, look at the pre-op. It's actually 30% of our pre-op sleeve patients experience nausea related to eating. But then 1 year out, about 45% experience nausea related to eating. That's sustained. You get a similar trend with regurgitation that's 2 years out. If you look at constipation and pain, you actually see a spike in constipation at around 2 years out, and that's sustained. And pain seems all post-op time points significantly more frequent than in the pre-op baseline. If you look at other symptoms related to eating, palpitations, dizziness, perspiration, diarrhea, hypoglycemia, as you all know, this is dumping syndrome related symptoms. What you see here is 1 to 2 years out, patients experience significantly more dumping syndrome related symptoms. And this is actually in line with prior data, because this is for sleep patients. Prior data suggests that dumping syndrome associated with sleep is actually higher than we previously thought. When you talk about dumping syndrome, you typically think of a bypass. But prior literature suggests 30 to 40% of patients who undergo sleep actually experience dumping syndrome. Talk about emotional distress. So on the x-axis, these are all emotional distress. So do you feel embarrassed when you're eating? Do you feel out of control when you're eating, ashamed, like a failure, etc.? And what you see here is that 1 year out from surgery, everyone seems to have a reduction in frequency of these negative emotions. So patients feel less embarrassed while eating, less out of control, less unhappy, less ashamed, disappointed, guilty, frustrated, etc. However, this benefit is transient. It only lasts about a year. And something happens at post-op year 1 where after that, they revert to baseline. If you look at eating-related behavior, so this is how often you feel satisfied while eating. Eating healthy foods, feel in control, chew thoroughly, avoid unhealthy foods, etc. All positive behaviors associated with eating. You see a similar trend here to the distress, where 1 year out, patients have healthier habits. They more often feel satisfied. They eat healthy foods, show self-control, chew thoroughly, avoid unhealthy food, and stop before full. But like the distress problem, they revert to baseline. This is only a temporary fix, where 1 year out, beyond 1 year, they revert to the pre-op baseline. There are 2 exceptions where long-term, so beyond 3 years out, they actually more often feel in control with eating, and they also more often eat the right amount. So I hope I convinced you that there is a quality chasm in bariatric surgery right now. We have all these clinical outcomes we measure, but we missed a very critical part, is the patient's voice and their experience related to eating. And what we found is that patients experience persistent eating-related symptoms that last long-term after a sleeve. Now, we talk about the GLP-1s. I hear a lot of people say, oh, but it causes nausea. Well, so do sleeves, and long-term, and significantly so, up to 20 to 30% more so than pre-op baselines. The other thing we found was that eating-related emotional distress and eating-related behavior is also, they improve, but only temporarily so within the first year post-op, and they revert to baseline. What can you use from this data? Well, first of all, we can enhance the pre-op counseling and deliver true informed consent. When we talk about bariatric surgeries, we talk about things like the incidence of internal hernias, marginal ulcers, things that are very abstract to patients. It's tough for them to digest. Talking about nausea, constipation, PO tolerance, those are much more relevant things to talk about that they can identify with. We could also manage patients' expectations postoperatively and also tailor a postoperative visit and interventions. Something happens at the post-op year 1 mark that after which patients seem to do worse. We should have a targeted intervention for that. Thanks to all the Emory group. Happy to take any questions.